welcome to UCT Virtual ENT. We're going to start off our session now. We have a very interesting session today from one of our registrars at the University of Cape Town. Dr. Pedicled, as you start loading up your presentation, welcome. Also, just a reminder for people joining us, just some house rules is that just to keep your microphones muted throughout the time of the presentation. If you have a question, you have two options. One option is to type your question in the chat function, and the second one is to use the raise hand function. You can do that, I'll see that, and then I'll give you an opportunity to ask your question. Okay, fantastic. Credit as you're loading up, just a reminder, we have a colleague joined us from all around the continent and now from outside Africa as well. So really the invitation is to hear from different practices, especially with a comprehensive and especially such an apt discussion like Dr. Pedicled is going to give us. So Dr. Pedicled, I know you're presenting on pedicle flaps and head and neck surgery. Please go ahead.
Thanks a lot, Tassir. Tassir, if you would just mind on your function, just allowing screen share.
Done.
Thanks. Let's try. Thanks, Tassir. Can you see that?
Loud and clear.
Fantastic. A very warm welcome to all local, regional, and international delegates. I'm Gerrit Viljoen, a registrar based at the University of Cape Town. This morning, we are discussing pedicled flaps in head and neck reconstruction. This is a very broad topic, and we could frankly spend a whole day on the intricate details of performing each flap. However, I'll focus on a history, pearls and pitfalls of these lifeboat procedures in head and neck surgery. An excellent starting point for aspiring surgeons is, of course, the Bula Open Access ENT site with chapters on each of these flaps. Defects following head and neck surgery can often be closed by direct suture. This applies to both the skin and mucous membranes. This technique is used when a defect is small and where local conditions allow adequate amounts of mobile tissue. However, for larger defects or in situations when direct suture is not applicable, surgical defects may be filled by free grafts, local skin flaps, with pedicled flaps that may be either axial cutaneous or musculocutaneous, or with free tissue transfer. During the first half of the last century, the repertoire of skin flaps was limited to random flaps, which were raised without any regard to known blood supply other than the subdermal plexus. These were therefore restricted to rigid length to width ratios to ensure viability. These flaps were differentiated according to how they were constructed, including the method of movement, conformation, and destination. This, however, forever changed when McGregor and Morgan discovered discrete, large, subcutaneous vessels with a predictable orientation. These vessels completely nourish huge cutaneous or axial flaps. In the 1970s, the work of Manchow was discovered and translated. He was a German who lived from 1866 to 1932. Axial flaps were based on vessels he had already described in 1889. In his words, larger cutaneous arteries appear from the fissure between muscles. Directly above the fascia, they divide into terminal branches and interconnect. As one can see on the diagram on the right, Mancho's mapped areas depict the anatomical territory of the cutaneous arteries and their branches. They are based on cadaver dissections and limited to the naked eye. Dissection of the deeper tissues revealed that the predominant supply to the skin followed facial planes either between muscles in the intermuscular septa or between the muscular branch bundles in the intramuscular septa as fasciocutaneous vessels. These vessels are particularly well developed in the following sites: adjacent to the mid-ventral and mid-dorsal line of the torso, in the axillary line, over the flexor surfaces of the joints, and radiating up from the skull base, where they are known as direct cutaneous arteries. They are also concentrated in the intramuscular septa of the extremities, where they arise from the nearby segmental arteries or their main branches. It is these vessels that form the basis of pedicled flaps in head and neck reconstruction. There are some simple rules to head and neck reconstruction. These are well summarized by some of the commandments of Sir Harold Gillies that relate to reconstruction in general. Sir Harold Dove Gillies was a New Zealand-born and later London-based otolaryngologist who is widely considered the father of modern plastic surgery. Who would think that plastic surgery would have its roots in ENT? His commandments are as follows: losses must be replaced in kind. Treat the primary defect first. Thou shalt provide thyself with a lifeboat. Thou shalt not throw away a living thing, and replace things into their normal position by recreation of the defect. The types of flaps are as follows. Sorry, I'm just gonna do that. Tasir, I just want to make sure if my screen is still sharing.
Gerrit, it's showing perfectly fine, yeah.
Okay, thanks. The types of flaps are as follows. There is not a, the local flaps can be divided in random and axial pattern flaps. Distant axial flaps, which includes deltopectoral, cervical, and occipitomastoid flaps. Myocutaneous flaps, which includes pectoralis major and latissimus dorsi flaps, and a free tissue transfer. There is not a single best flap for specific scenarios, and each local, random, or axial pattern flaps. Next up, we've got distant axial, which includes the deltopectoral, cervical, and occipitomastoid flaps. Myocutaneous, which includes pectoralis major and latissimus dorsi flaps, and free tissue transfer. There is not a single best flap for specific scenarios, and each patient needs to be managed according to patient factors, tumor factors, and institutional factors. Institutional factors especially play a large role. No use in doing free tissue transfer if the skill is unavailable. As Carlos Chiesa would say, it is like going to your local supermarket and choosing the best available option to suit the patient's needs. There is no use for a doctor in South Africa asking his local SPAR for something that's only available at a Tesco in the UK. What are the pros and cons of pedicled flaps? The advantages are that they are relatively straightforward. They are reliable, they've got adequate blood supply, they provide lifeboats in salvage surgery, and are useful in the presence of infection. The disadvantages are that they are bulky, cannot be tubed, they present some donor site morbidity, and are also a compromise between the ideal reconstruction and the surgeon's skill set. Important factors to take into consideration with flap surgery are the following: the age, operating time, cardiovascular disease, diabetes mellitus, and prior radiation. Frequently, pedicled flaps even seem to be preferable over free flaps. Many reports regarding the elderly in relation to microvascular free flap reconstruction agree that age is a risk factor for poor surgical outcome. McCrory et al. Described that operative time was statistically much longer for free flaps than for pedicle flap procedures, 9 hours versus 5 hours. Furthermore, older patients are less capable of coping with large fluid shifts and significant blood loss, whereas free flap reconstruction are more often associated with the need for blood transfusion. In addition, cardiovascular disease proves to be an important factor in free flap reconstructive failure, a condition which proves to affect the majority of adults past the age of 60 years. The use of free flaps for reconstructing previously irradiated patients or patients who underwent prior chemoradiation is also much debated in literature. In a review, Wong et al. Points out that prior chemotherapy or radiotherapy can cause significant scarring and vessel damage to the utilized vessels for microvascular free flap reconstruction with obvious negative consequences. Furthermore, Schulze and Moscow reported a reduced clinical success rate of 84% of free vascular grafts in head and neck patients with previous radiotherapy of 60 to 70 gray. Axial flaps are therefore based on named arteriovenous pedicles. They run within the superficial skin, superficial to the underlying muscle layer. They have extremely good blood supply and can be raised over much greater length than random flaps. Axial flaps include the following: forehead flap, nasolabial flap, temporoparietal facial flap, facial artery myomucosal flap, and a submental artery island flap. I'll focus on the latter three. And like the original mini of old, they are nippy, small, quick to park and tie defects, and easily blend in by replacing like with like. First up is the temporoparietal facial flap. The temporoparietal facial flap is a versatile local rotation or free fascial flap for reconstruction of the head and neck or extremities. The flap was first described by Golovin in the 19th century for orbit reconstruction. More recently, it has been popularized by Brent and Bird and others for microtia repair and auricular reconstruction. Its unique characteristics are a remarkably robust vascular supply with a very thin and pliable flap with minimal donor site morbidity. The background of this flap is as follows. In 1988, it was used for reconstruction of the external ear after a horse bite, and also used for reconstruction of the lower eyelid. In 1983, Brent et al. Reported the successful use of the flap as an axial pattern fascial flap, random pattern fascial flap, and a free fascial flap for secondary ear reconstruction. And in 1993, Shenny et al. Described 21 cases using the flap for a variety of reconstructions in the head and neck. The arterial supply of the temporoparietal flap is the superficial temporal artery, a terminal branch of the external carotid artery. The vessel classically has a number of branches above the zygoma, with most patients having a prominent frontal branch and dominant branch that ascends towards the vertex of the skull. The venous drainage is via the superficial temporal vein running with the artery. There is some variation in venous anatomy, with a small percentage of patients having venous drainage through the postauricular vein or occipital veins. The temporoparietal fascia lies just under the subcutaneous tissue of the lateral skull. Important landmarks include the arch of the zygoma, the pinna, and the usual landmarks of the facial nerve. Indications of this flap include the following: auricular reconstruction, as a pedicle for vascularized calvario bone grafts, for use as a composite skin and cartilage graft from helical root for alar reconstruction, composite fascia and hair-bearing skin for scalp and lip reconstruction, and as a soft tissue filler in temporal and parotid defects, and it can also be used as a microvascular free tissue graft. Further indications include coverage of large scalp defects, coverage of contralateral temporal defects as a double-layered fascial graft, and in nasal and oral reconstruction. After elevating the flaps, the superior, posterior, and anterior borders of the temporoparietal flap are incised. And after careful elevation of the flap with protection of the superficial artery pedicle, the flap is draped into the recipient bed. The pliability of the flap makes it uniquely suited for draping over cartilage and bone. Here follows a few clinical applications. In the first picture, one can see a defect following a left inferior maxillectomy. On the next picture, temporalis muscle flap is elevated. The next picture shows reconstruction of the inferior maxillectomy defect. And the last one, the temporalis muscle filling the orbit. The pitfalls of this flap is a pronounced concavity of the temporal fossa, which may be filled with fat graft, hydroxyapatite, or molded prosthetic implants. And following inferior maxillectomy with reconstruction, it's not possible to insert dental implants or to fit and retain an upper denture if bilateral flaps, maxillectomy and flaps were used. Next, we come to the facial artery mymucosal flap. It's also known as the buccinator flap. It's an axial pattern flap and was first described by Pribas et al. In 1992. As one can see on the diagram, the flap is based on the buccinator muscle and its relationship to the facial artery. Medial to the buccinator is submucosa and mucosa, and lateral to the buccinator is the external lamina of the muscle, the masseter, buccal fat pad, and facial artery and vein. Clinical applications of this flap include as an inferiorly based or superiorly based flap, and it's suited for small mucosal defects in the lip, floor of mouth, tongue, and palate. The pearls and benefits of this flap includes that it's a versatile flap which can be used for a variety of defects. It's very reliable, simple, and quick to raise, and it replaces mucosa with mucosa. Furthermore, it's sensate, presents very little donor site morbidity, is elastic and malleable, and can conform to complexly shaped defects. It can be of worth to map the vessels with Doppler to know exactly where the artery is running. The next picture shows how the flap is elevated, and here is two reconstructed defects. On the left, reconstructed antral palatal defect, and on the right, reconstruction of the floor of mouth. Distant axial flaps include the following: deltopectoral, pectoralis major, supraclavicular, latissimus dorsi, sternomastoid, trapezius, and platysma. I'll focus on the deltopectoral and pectoralis major flaps. And hold on to your seats for the pectoralis major flap. Like the Toyota Land Cruiser, it is extremely versatile and reliable with an excellent range and can be very fast if required. The deltopectoral flap was first described by Bakamjian and Littlewood in 1964. It's an axial pattern flap and is designed on the anterior chest wall between the line of the clavicle and level of anterior axillary fold. Its vascular supply is from the upper 3 perforating branches of the internal mammary artery, and it emerges through the medial end of intercostal spaces. Its boundaries are superiorly the clavicle, laterally the acromion, and inferiorly a line from the nipple to the anterior axillary fold. It can be used for one-stage reconstruction of the anterior neck skin, as a reconstruction of a defect by passing as a bridge over normal tissue, reconstruction of large defects on the lower face and upper neck, and in the repair of a pharyngocutaneous fistula. However, with this indication, muscle bulk is often required with skin, and other flaps like the pectoralis major flap is preferable. The pearls and benefit of this flap include that it will extend to any site in the neck, and occasionally even up to the level of the zygoma. It retracts from side to side after elevation, and it may even elongate slightly over time, particularly in the over 60 age group. It has an anomalous pivot point. It provides better color and texture match compared to free tissue transfer, and it is less bulky than a pectoralis major flap. Clinical applications include shown in the following pictures. Firstly, the position of the first 3 perforators and the deltopectoral groove is marked. The flap is elevated in the subfascial plane to expose the pec major and the deltopectoral muscles. In the next picture, the flap is positioned in the final position to cover the defect. And the last picture shows the inset flap with primary closure of the donor site. Some pearls with regards to gaining additional length is to cut back over the sternum below and medial to the most inferior perforator, as shown here, to extend the flap over the deltoid muscle or include an inferior 90 degrees extension. And lastly, to use tissue expanders placed deep to the pectoral fascia to increase area of skin available for reconstruction. The pitfalls of this flap is that it has a limited arc of rotation. The fasciocutaneous pedicle limits the reach of the flap, and it might lead to an unsightly donor defect, especially if a skin graft is required. This picture just illustrates the scarring from skin grafts and flap contracture band of the neck. Next, we come to the myocutaneous flaps, which includes the pectoralis major and the latissimus dorsi flaps. One of the most important discoveries in the last 30 years is that the skin over most parts of the body receives its blood supply from small musculocutaneous arteries that enter it from the underlying muscle. It subsequently became apparent that an obvious way to move large area of skin for reconstructive purposes was to transpose the skin with its underlying muscle vascularized by its dominant blood supply. The pectoralis major and latissimus dorsi flaps represent the workhorses for many head and neck reconstructive surgeons, and a detailed understanding of the anatomy and harvest technique will be a significant asset to the head and neck surgeon. The muscles are ultimately supplied by segmental vessels that have a similar perfusion pressure to the aorta. They run deep within the muscle and give off perforators that enter the muscles and provides communication between the segmental vessels and the musculocutaneous vessels in the skin. There may be several arterial pedicles. The artery is usually accompanied by 2 venae communicantes that unite after leaving the muscle to drain into a major regional vein. The essential surgical points with regard to myocutaneous flap is that blood supply to the muscle is axial. However, blood supply to the skin upon the muscle is random. Therefore, a minimum size of skin paddle, usually 5 times 3 centimeters, needs to be taken to ensure enough perforators to supply the skin flap. And smaller skin paddles may therefore not survive. Coming to the pectoralis major flap, its first description was assigned to Arjan in 1979. However, it was reported in 1977 by at least 2 other authors. From there on, it has exploded into an impressive number of modifications, which includes reconstruction of different types of defects to increase its mobility of its reach and to reduce donor site morbidity. Its anatomy includes origins of the muscle from the clavicle, sternum, and slips from the upper 7 ribs. Its insertion is in the bicipital groove of the humerus, and its blood supply is mainly from the thoracoacromial artery. It has a wide range of reconstructive indications, including reconstruction of soft tissue defects of the oropharynx, oral cavity, hypopharynx, and skin of the neck. It can be used to augment pharyngeal repairs following salvage laryngectomy, and it can be used to cover carotid or jugular vein blowouts. Next we come to flap design, and with regards to surface markings, a line is drawn from the shoulder to the xiphisternum, and another line from the midpoint of the clavicle, which intersects the first line, corresponds with the pedicle. The skin paddle is positioned over the pectoralis major muscle along the pectoral branch of the thoracoacromial artery. In order to ensure that the pedicle is of adequate length, the distance between the top of the skin paddle and the inferior edge of the clavicle should equal or exceed the distance between the recipient side for the flap and the inferior edge of the clavicle. Should additional pedicle length be required, the flap may be extended up to 2.5 centimeters beyond the pectoralis major muscle inferiorly at the costal margin. However, with the knowledge that the flap then becomes a random pattern flap and the blood supply more tenuous. The first picture indicates the dissection of the skin paddle onto the pectoralis major flap. Following a few steps, the pectoralis major is elevated from the pectoralis minor along the lateral margin of the muscle. The flap is passed over the clavicle through a wide skin tunnel, and it's important to check that the pedicle is not twisted so not to compromise the pedicle and the blood supply. Pearls with regards to the pectoralis major flap to gain additional length include to transect the pectoralis major muscle just below the clavicle, taking great care to preserve the vascular pedicle. The benefit of this is that the pedicle is directly applied to the clavicle without intervening muscle. And the bonus is that this avoids the unsightly, bulky pedicle over the clavicle. The second way of gaining additional length is to pass the flap behind the clavicle. For some references and good reading material, I've included a few literature articles. The first one is this: the contemporary role of pectoralis major regional flaps in head and neck surgery, published in the ACTA in 2014. In this excellent article, the history, present role, and current indications of the most widely performed head and neck reconstructive procedure ever has been reviewed. Next is an article on head and neck reconstruction with pedicled flaps in the free flap era. The aim of the study was to assess whether pedicled flap reconstruction of head and neck defects is inferior to microvascular free flap reconstruction in terms of complications, functionality, and prognosis. The results showed no significant differences in terms of functional outcome, flap necrosis, and complications in each type of reconstruction. In this retrospective, non-randomized study cohort, pedicled flaps were not significantly inferior to free flaps for reconstruction of head and neck defects. The last study I'll focus on is the regional flaps in head and neck reconstruction, a reappraisal, which appeared in the Journal of Oral and Maxillofacial Surgery in 2015. This study included data and outcomes on 45 pedicled flaps. 2 myocutaneous pectoralis major flaps were complicated by necrosis of the cutaneous paddle, 1 complete and 1 partial. No complete loss of any of the 45 flaps was observed. At 6 months follow-up, 2 patients had died of multi-organ failure after prolonged sepsis. The 43 remaining patients had acceptable morphologic and functional results. Conclusions of the study was that regional and free flaps appear to compete in many cases for the same indications. But from these results, regional flaps can be considered reliable reconstructive choices that are less expensive than their free flap alternatives. In conclusion then, choose wisely and take into consideration patient factors, tumor factors, and institutional factors. Pedicled flaps can be considered reliable reconstructive choices, and they provide important lifeboats when seas get stormy. Thank you very much.
Thank you very much, Gerrit. That was very comprehensive. I quite enjoyed that. I must admit, I think I'm more of a Land Rover man than a Mini man. But thank you very much. Very, very nice. I'd like to invite a few people that have joined us on our participants. Just to kick off, Professor Johan Fagan from University of Cape Town. Any comments from your side?
Well, thank you, Gerrit. That was an excellent review. I'd just like to take issue with the one statement you mentioned, that you can't tube pedicled flaps. Now, we do tube pedicled flaps. The pec major flap you can tube to reconstruct the hypopharynx. It is bulky, but most certainly that can be done. And the other issue is that it's always important to document in your surgical notes what vessels you preserve at the time of neck dissection. For instance, if you've done an oral cavity resection, so document whether you preserve the facial artery, so that if you need to go back and do a salvage, so buccinated flap, then you know at least that flap's intact. But most certainly, it's very important to have a good knowledge of of the pedicled flaps, even if you're in a center where you do many free flaps, because they are a very good fallback situation. And perhaps we can ask Otti van Zyl to make a comment. I think he's on the call.
Dr. van Zyl, if you're there, perhaps just unmute your microphone.
I'm here. Can you hear me?
Yes.
Hello?
Yes, we can.
Yes, sorry. This is an unskilled plastic surgeon.
No problem, Prof. We can hear you loud and clear now. Please go ahead.
Yeah, a very nice presentation, a good summary of all the options available. There are a few other options as well, which is not necessarily relevant here. I agree on many of the things, and I'm fortunate that I've come from an area where we didn't have free flaps, and I started my head and neck surgery when free flaps weren't available, at least not at Frere Hospital. I see Frere ENT is also here. And we had to rely on pedicled flaps. And to bring perspective in it, the results at that stage wasn't fantastic. So much so that in Groote Hospital, they stopped doing major reconstructions and they relied more on radiotherapy for advanced cancers than reconstructions. That doesn't mean that the results or the flaps aren't good, but one must remember that major reconstructions, the basis of it has improved. Everything has improved since free flap reconstructions. So for major reconstructions, free flaps still is the best choice. The other thing is one mustn't try to extend the indications for pedicled flaps. And then you would get bad results. And one is, take the pectoralis major flap, often gets a bad name, and it's an excellent flap, but it often gets a bad name as a bailout procedure, meaning you've done a free flap, for instance, the free flap has failed. Now you do a pectoralis major flap, it often fails again because it's done at the time when there's infection and it's not a good time to do the reconstruction. The problems still are bulkiness of these flaps and less maneuverability, and you can't change the flaps much. You can't get a three-dimensional reconstructions with pedicle flaps, which you do get with microvascular flaps. Remember the success rate. You quoted some articles there, and in clinical experience, I do not totally agree there. The success rate of free flaps is about 97%. And if you press a axial flap in size and length, you're going to lose the tip of the flap. For instance, the delta pectoral flap that you mentioned, you said you can extend it over to the tip of the shoulder. You have to delay it then. And even then, you might lose the distal part. And that's a problem with axial flaps. The most important part of the flap is the distal tip of the flap, because that's where your reconstruction part is. And that's the part that you might lose. So you might end up with a failed reconstruction, even if it is a small part, and then you end up with a fistula or things like that. But these flaps are fantastic and well worth the local flaps in the head and neck area are fantastic, like the submental artery flap, especially for color, same color of the skin. That goes back to Harold Gillis' principles. Replace like tissue with like tissue. But again, one must realize and be very careful that your drainage area of head and neck cancers in the orofacial area is to the submental area, for instance. And one must be aware that you are elevating a flap to that drainage area. For the rest, I think that is a lovely presentation. I don't know, I haven't got much else to say. Thank you.
Thank you very much, Dr. Van Zyl. Gerrit, do you have any comments after those words from Dr. Van Zyl?
Tassir, no closing or any more comments. Thanks.
Great. I would like to invite Dr. Kenneth Baidu from Ghana to perhaps comment on what the practice is in West Africa and that part of the continent. Dr. Kenneth Baidu, are you there?
Yes, I am. Good morning to everybody.
Good morning.
I must say we are very happy for this presentation, and here in West Africa, we rely mainly on pedicled flaps, and because we get to do quite a bit of extensive head and neck surgery, our plastic surgeons help us out. We've done a few, well, I can count on my fingers the number of free flaps, basically the radial free form flaps for oral cavity recons. So, and by and large, our workhorse has been the pec major flap. Thank you.
Thank you very, very much, Dr. Baidu. It's always nice to hear from different institutions continentally. I'd like to also now hand over to Dr. Shazia Pierre, who also has a question specifically in regard to pediatric. Dr. Shazia Pierre, please go ahead.
Thanks, Desir. Well done, Gerrit. That's a very good presentation. We don't see many cancers in head and neck, but for the ones we do see, often they are locally quite extensive, and after the excision, there's the opportunity for reconstruction. So I just had a question to the senior panel, Prof. Fagan, Prof. Van Zyl, and some of the other people. What is the, if at all, is there an age restriction for free flaps? And with the axial flaps, is there a time as well? I mean, this is obviously not common, but when we do see them, there's obviously that consideration for reconstruction for head and neck cancers in children. Thanks. Thanks, Desir.
Thanks, Shazia. Professor Fagan, would you like to reply to that?
Yeah, I think Oti is probably a better place to reply to that question.
Yes. When you talk about age restriction, are you talking about young age or old age? For old age, there isn't really an age restriction. Can you hear me?
We can hear you.
Yes, yes.
In my hands, there's no age restriction for older people. Yes, they've got an increased mortality rate and morbidity rate, but we've done free flaps in 90-year-old people. The point is, don't make it a big operation, and don't try and do the resection and the reconstruction yourself. And if you are very slick and get the change over time and together easily, it is not such a major more morbidity than a pectoralis major flap. In fact, probably less so, because you're going to get less chest problems in the post-operative period compared, for instance, to a radial forearm flap that has got no morbidity, life-threatening morbidity in the short term. In children, that's difficult to say. Going to a young age, free flaps can be done at any stage. The problem is just the size of the vessels.
Oh, okay. All right, thanks.
Okay, thanks, Shazia. Thanks, Dr. Van Zyl. Well, we're just about to close now.
Desir, can I ask a question?
Absolutely. Please go ahead, Prof.
It's something that I've never done personally, but I'd like to know whether anyone on the continent has experience of incorporating rib into a pectoralis major flap to reconstruct mandible. If there's anyone with that experience, if they can possibly comment.
Any takers?
If I can comment again about the rib, in the days that we were doing mandible reconstructions, this is Oti van Zyl, by the way, the rib was less successful from a vascular point of view. And I think the reason is that the muscle is less attached to the rib in the pec major flap. And there is small vessels giving a periosteal supply, but we used to use the trapezius muscle, we used to call the spine of scapula flap, and you use the spine of scapula to reconstruct the mandible, and there's more muscle attachment, and I think it's the muscle attachment to the bone that probably gives better blood supply. But the rib never featured as a good or excellent bone replacement with, for instance, the pectoralis major flap, but the trapezius flap did gain some value.
Well, just to follow on, the reason that I asked the question is that that if you don't have the ability to reconstruct mandible with the fibular flap, then it's always that difficult case where the resection has to just cross the midline of the mandible, and you don't want to end up with an anti-gump deformity. And the question just is, if you don't have free flap expertise, is there a possibility of using a small segment of rib just to get that extra extension to the mandible, so you can turn an inoperable case into an operable case?
If I may comment again there, Professor Fagan, yes, and I think short segment bone, for instance, with a pectoralis rib combined flap, it may survive, and if it does not survive totally, at least if you've got good soft tissue surrounding the area in that mandible region as well, and it's a short segment, it may survive and may be worthwhile. You don't lose anything, but it may be worthwhile doing it that way.
Thank you very, very much, Dr. van Zyl and Professor Fagan. If you just look on the chat functions, I've put two very important links for everyone just to refer to. The one is the one that Gerrit Viljoen was referring to with the Open Access Atlas of Otolaryngology Head and Neck Surgery by Professor Johan Fagan. And the second is our YouTube channel, where we've posted a select group of past videos that have been done on this platform. As we wind up, Professor Siedert, maybe from the University of the Free State, any comments from your side on the practice there? Professor Siedert, any comments from your side? We might have lost him there, but no problem. I think, Gerrit, we'll probably now close off. I see we're also pressed for time here. Any closing comments from your side, Gerrit?
No closing comments. Thanks for hosting us here, and thanks for the opportunity.
Thank you very, very much. I'd like to end today's session and further invite you to this Friday session that we'll be discussing three very interesting head and neck cases. So we'll be starting at 8:30 in the morning this Friday, South African Standard Time. So we'll see you then. Thank you very, very much.